This paper addresses a common dilemma that we see in surgical practice. It is quite common for patients today to be on antiplatelet agents like clopidogrel, and some of these patients also end up requiring a laparoscopic cholecystectomy. The dilemma which then arises is that do you discontinue the drugs around 4 to 5 days before surgery and increase the risk of thromboembolic events, or do you maintain it and thereby have to live with the risk of increased bleeding? At the present time, there is no real clear evidence that can make any strong recommendations about whether clopidogrel has to be discontinued before a laparoscopic cholecystectomy. In this study, the authors looked at their experience and on the basis of a large series of patients who had undergone laparoscopic cholecystectomy were able to first identify a group of patients who had undergone laparoscopic cholecystectomy while on clopidogrel, and they were able to find about 36 patients. What they then did was that from the same database, they extracted a matched cohort based on ASA score and indications for surgery, the only difference being that these patients were not on clopidogrel. Clopidogrel had been withdrawn, and they were able to find another matched series of 36 patients for the comparison. What the study did basically was compared patients who underwent laparoscopic cholecystectomy on clopidogrel with those patients who underwent the surgery in whom clopidogrel had been withdrawn. The authors then looked at a wide variety of outcomes, and they found that with regards to operative times, estimated blood loss, length of stay in the hospital, and 30-day morbidity, the common parameters by which you would assess outcomes after this kind of a situation, they found that there was no statistically significant difference in any of these parameters between the two groups. The authors therefore conclude that laparoscopic cholecystectomy performed on patients maintained on clopidogrel during the perioperative period did not produce an increase in blood loss, operative time, 30-day morbidity, or length of stay. Now, how valid is their conclusion? First of all, the analysis is retrospective. The numbers are fairly small, just about 36 in each group. They did have controls, but however, these were not obtained on the basis of randomization, but this was on the basis of case control. And therefore, for all these reasons, this is not a very good study. Ideally, this should have been done in a prospective manner where patients should have been randomly assigned to either being taken off clopidogrel or left on clopidogrel, and then the outcome assessed. So although it's interesting, the paper is relatively weak.